पेशेंट्स पता नहीं कुछ.
Ma'am, a priming gravida patient has come at 37 weeks period of gestation. She had 2 seizure episodes in last 2 hours.
Okay. Is this your known
Yes.
seizure disorder?
No,
Or
ma'am.
first time seizure?
This is the first time she had seizures.
Anything else from the history?
No, it seems like her blood pressure had been on higher side when she was referred and she received Depin before referral.
She looks drowsy, post-ictal. Let's shift her to eclampsia room.
Yes, doctor.
Somebody get the eclampsia box.
Yes, I'm bringing
Ma'am,
it.
the
Yes.
BP is 200 by 120. Sister, let us shift her to the eclampsia room. Please give her a calm, comfortable environment.
Yes.
And ma'am,
It's a touch oxygen.
anything else? Maxilf.
You get the Maxilf and the Lubitalol out of the eclampsia box and start. First you resuscitate the patient. A, B, C always remember.
Okay.
Airway,
Okay.
breathing and circulation. First maintain that.
Right,
Proper
doctor.
करो, oxygen लगाओ, sister जी venti mask
हाँ जी.
attach कर दो. You review the referral.
Okay,
Has
ma'am.
she seen anything? Where did she have the seizure?
Season आ रहा है.
Ma'am, she had her seizures on the way to PGI. Before that, she was not given any antihypertensives or anything.
ऐसे ही refer कर दिया.
Ma'am,
Ma'am, 200 by 120. What shall I start?
20 milligram IV Lubitalol stats. Sister जी
Okay.
get that. Who is following Maxilf?
ma'am,
Yes, I'm doing
sister is
that.
preparing.
Sister?
I'm giving loading Maxil dose.
Okay.
चलो railings ऊपर कर लो.
Sister, and also give 20 milligrams of IV labetalol to the patient.
Yes, I'm administering it.
I'll attach to the monitor.
Dr. B, I have given it.
Okay.
Let me know the BP in 15 minutes.
Okay, okay.
Location, please help me giving
can
lateral
attach the
position. Thank you. It's right.
Ma'am, it's 15 minutes and the BP is 170 by 110 now.
Okay, make it 40.
Sister, 40 mg labetalol.
40 again?
You have it, right?
Yeah, I have. Can I get?
Yeah. So you are giving 40 mg labetalol. Okay.
Yes, I have.
How are you now? Suno? Okay. Nahi. Ma'am, she is still drowsy and the BP is 160 by 110 after 20 and 40.
So she is going to need 80 milligram. Okay, let's give her 80 milligram.
Sister?
Hope this works.
Yes.
80 mg of labetalol.
80.
How much cumulative dose that will make for this patient?
Ma'am, 80, 40,
Please take
140 till now.
So we are still left with some. Hope we don't have to resort to anything else.
Okay.
Okay.
Hope this works.
80 mg. Done.
Take a history, like what are the investigations that she's got? Anything?
No, nothing on the referral as so far. I have sent fresh investigations.
Okay. Ma'am, and it's 15 minutes now and luckily BP is settled 150 by 100.
Okay, that's good, na? We didn't have to give anything else.
Ma'am,
So next is the baby. You have seen clinically.
I've seen it and baby is like term size, scephalic presentation and fetal heart rate is also regular.
Okay, and you must have retrieved the records by now, na?
Yes,
What's
ma'am.
the baby like?
Ma'am, the grossly congenital malformations have been ruled out and baby is appropriate for gestational age according to her last ultrasound.
And who is following the investigation of eclampsia and when are they going to arrive?
Ma'am, I'll go
You
and
go and collect. I'll scrub and come, sister. We'll have to do cervical assessment early because definitive management of eclampsia will always be delivery. So I'll scrub and come, you make arrangements. by
Yes, I'll arrange the PB examination.
Shivani, take a CTG tracing too.
Okay, sir.
Ma'am,
then. And
let's.
yeah, I forgot arrange for catheter as well.
Okay. Let's
I'll
get us.
catheterize simultaneously.
Okay, we're keeping it ready. Harpreet, please help me.
Ma'am, help!
Ma'am.
Patient is having seizures, help!
Sister, get me 2 gram.
Yes, I'm loading that. Yes.
Ma'am, I'm controlling
Yeah,
her.
the ABC again. Na? Maintain
electrolyzed
the-
her head.
Get me an
I'm
airway.
securing your airway.
Give me suction.
Give me
I'm
an
giving 2
airway.
gram IV loading Maxil.
You're giving 2 gram of IV max.
2 gram
Yes,
IV
yes.
Suction,
Maxil.
sister. Suction.
Suction is here.
Okay. So,
I think the seizure has aborted as of now.
So you withhold the fetal assessment, the CTG for a while, let her stabilize and let the maxil go. Then we'll assess. So you let me know the CTG.
Okay.
I'll assess the patient and come.
So 1 hour has elapsed since the last seizure And
Did you take the
patient looks
CTG?
stable now. Her BP is under control. She has received magnesium sulfate for seizure control. And as we all know, the definitive management in a patient of eclampsia is to deliver her. So let's see what preparations are being done for her vaginal delivery.
Ma'am, I've got the investigations. Show it to the ma'am.
Ma'am, her CTG is reactive.
Array investigations. Ma'am, HB is 9.6, platelet is 1.8 lakhs, PTI is 83%. I think we can have a vaginal delivery for her.
Yeah. And the CTG with the maxilf looks quite reassuring.
Yes, ma'am.
Hope I'm able to do an amniotomy in the first PV itself and start labor.
Okay.
Shivani, please document.
Okay.
Oh, I'm able to negotiate the os. She's 2 centimeters, 50% effaces the coccus, please. Lighter is cleared.
Okay.
Sister, well in time we are going to start Pitocin. We'll get
Okay.
the Pitocin on flow for augmentation of labor.
Okay.
I don't want any delays with eclampsia here.
Sister,
Okay.
kindly start oxytocin infusion for her.
Right, doctor.
And the partogram, who is making the partogram?
Ma'am, I'll do it.
Okay.
Sister, how are you preparing oxytocin for her?
Yes, for it I have taken 30 international units of pitocin and in 500 ml NS.
Okay, and started in 3 milli international units per minute in an infusion pump.
Right, doctor.
So our patient continued to be stable. She maintained her BP in the range of 140/90 to 150/90. Augmentation of labor was done with escalated doses of concentrated pitocin. Patient was kept on continuous electronic fetal monitoring. Fetal status seemed reassuring, and her next dose of Maxilf is due now. Let's see what prerequisites are being checked.
Dr. Darshan, kindly check the knee jerk of the patient. It's time for her next maintenance dose.
Yes, yes. Ma'am, the knee jerk is absent.
एक ही डोज से ध्यान से देखा था ना
हाँ.
बाकी रिफ्लेक्सेस देख लो
Ma'am, I have checked the ankle, biceps, triceps also, and they are also absent.
ओके आउटपुट तो ठीक है ना सिस्टर जी
Yes, doctor, it's adequate.
Yes,
सब
yes.
ठीक है ओके
Sister, how was the output?
It's around 50 ml per hour for previous 2 hours.
Okay.
okay so let's wait for one more hour we'll assess again
So shall I withhold this dose of
Yes,
Maxilf?
as of now, withhold the Maxilf, and after 1 hour, let us assess again.
Okay.
Okay. आप ही बोल दो जाओ
Dr. Darshan, it's been an hour. Can we check the knee jerk again, please?
yeah and output is fine, right?
Yeah, output is fine.
Oh sister, knee jerk is brisk. I think you can go about with the Maxilf maintenance dose.
Right, I'll give 5 gram IM Maxilf now.
Yeah I think अभी PV करना होगा.
So it's 6 hours down the lane now. She has had no fresh seizures and patient's vitals have remained stable. And it's time for repeat per vaginum examination. Let's see what are the findings.
अब तक तो अच्छा ही प्रोग्रेस कर रही थी कितना मिली इंटरनेशनल यूनिट्स चल रहा है
Ma'am, we have gone till 54 and she's having moderate regular contractions.
okay and since how long
Ma'am, since 1 hour she's having
and how is
moderate
the fetus doing Shivani how is the
Ma'am,
CTG
the CTG has been reactive
okay
and there is
Yes,
no
PV
seizure
examination, right?
episode after that.
okay how is the blood pressure doing
Ma'am, 140/100 and I've charted her on oral drugs also, but we haven't got any time now.
And what are our findings?
she's fully dilated
Oh.
Okay.
pleasant na fully dilated fully phased
Hmm.
and vertex at 0 sutures in AP With eclampsia, so she'll be assisted delivery. So Darshan, what preparations we are going to make for her delivery now?
Ma'am, we have to cut short a second stage, so we have to have an assisted either outlet forceps delivery probably.
पर अभी तो स्टेशन ऊपर है.
So we'll assess the contractions, inform neonatologist meanwhile, continue the max self.
Preparedness for PCH.
Should I prepare the patient for
Yeah,
with
get the
delivery?
delivery
Yeah.
table ready.
Right.
I'll inform you,
I'll do it.
neonatologist.
You get back in touch. And outlet के लिए I need one assistant, so one of you come.
Okay.
I should keep the outlet forceps ready
Yes,
too?
yes.
Okay, doctor.
बस.
As we can all see, they're preparing the patient for normal deliveries. Delivery? Outlet. Sorry, outlet forceps delivery.
Dr. V, everything is ready.
उस तरफ से फिक्स कर दीजिए इस पे जा.
Sister, he's
नहीं करते हैं इसको टांग रखना.
बहुत ऊंचा है.
बस हो गया.
बस आउटलेट निकालो.
You get ready with the outlet.
Right. Arpit, have you kept outlet on this side?
Please give me outlet process. So Suji, jelly please.
चलो मैम करता हूँ.
दे दो ना ब्लेड.
मैम करता हूँ.
I'll reassess the patient, and if she qualifies for the outlet, I'm going to do an outlet delivery. I'll check the blades, do a phantom application. Shivani, you pay attention.
Okay.
Okay, leg locking ठीक है. Suji, infiltration.
ऐसे ऐसे छोड़ दो. हाँ जी. I'll take care.
I'm introducing blade.
ठीक
Hold the blade.
ठीक है सर.
Shivani, support.
टेबल है ना.
Darshan,
Yes, ma'am.
you tell me when the contraction is there.
ठीक है सर.
Yes, ma'am. She's
Okay, I'm
having
pulling.
one. Okay. With a one pull, very good.
Suchi ji, ले लो.
Yes, doctor.
What?
बस उधर ही.
अच्छा पोजर लगाती हूँ मैं. Somebody check the vitals.
Yes, ma'am.
I'll be suturing the episiotomy myself.
So as we all saw, our patient underwent a successful outlet forceps delivery and episiotomy is being sutured by the senior most available obstetrician in the labor room.
Ma'am.
And she's giving some instructions to her junior. Let's see what they are.
So with that kind of blood pressure, she is very high risk to develop hematomas and everything. So it should be secured really nicely. And what is the most important thing to do for her?
Continue postpartum.
Yes, that's very fine. Continue maxil postpartum for 24 hours. Adequate analgesia. And
Okay.
just keep her in the same calm, comfortable environment. Okay, I'm done with my epi. The catheter is in place.
Sister, continue the Maxelf in the postpartum period too.
Right.
वापस बेड में कन्वर्ट कर लीजिए.
Yes.
She's that eclampsia that you delivered yesterday. But she's still drowsy. I don't think she's.
She should be better by now.
Oh.
Mrs. M.
इसकी chart दे दो.
He's not responding. Shivani, you assess clinically.
Ma'am, I have checked the patient. She has no pallor. There is no tachycardia, and I have also
See the
checked
records, the output, the vitals.
the
Chart is
output
here.
has been
Has
adequate.
been all right.
Yes.
Ma'am, her fresh investigation says that hemoglobin is 9.8. Platelets and RFTs are also within normal limits.
You tell me her random sugar and electrolytes in detail.
Ma'am,
Anything responsible which can tell her why
Random
neurologically
sugar
like
is
that.
also 104 in the last hour.
With just eclampsia, she should be better by now.
I think so because per abdomen uterus is well retracted. I have checked episiotomy. It is normal. There is no source of bleeding in our patient.
When we
Yes,
were not
ma'am.
around. Doesn't look like an obstetric cause can explain a neurological status like this 24 hours post last seizure and having received all the Maxil. I think we could be sitting on a neurological complication of eclampsia. So you get in
Maybe.
touch with the neurologist. We'll need his word here.
Okay,
And
ma'am.
you arrange for some imaging because he's going to ask for it.
As a neurologist, what we would like to see is any evidence of papilledema, one, cranial nerve palsies, any focal neurological deficits, the reflexes, any asymmetry, and of course we start from the GCS, how the patient is, what is the M response, and then the reflex asymmetry and focal neurological deficits. So usually we start with the general whether there is a spontaneous eye opening or not, or what we call the EV and M score, right? So we definitely ask the patient, aankhein kholo. If not, then whether the patient is, wincing or opening eyes on painful stimulus, or she's not at all opening the eyes, and then whether she's speaking anything or responding to your commands or not, and what is the M status of the patient, whether she's moving the limbs with on commands or on painful stimulus, or whether it is a flexor response or an extensor response. Depending upon that, we grade the degree of coma in these patients, right? And after that, once we have decided whether it is a mild, moderate, or a severe coma, we further do a detailed neurological examination to see if there is something which we are missing, or whether it is a complicated eclampsia, or there is something underlying in the brain which is contributing to the persistent altered sensorium, which was not expected in this case. Okay. So there is no history of fever in this case,
No, sir.
and the neck is quite supple. There is no meningeal irritation, and the tone is on the lower side. Probably she received Maxel in adequate dosages, and but on painful stimulus, look, she is not at all moving. I'm trying hard, but I'm not getting any response, not even extensive posturing or anything. So let us see the reflexes. I'm using this one just because it has got a broader one, so I use this stethoscope while I'm on call. So and then we check the plantar. Okay. Examination wise, the reflexes are more or less symmetrically elicitable. The knees are quite sluggish. The plantars are flexor. The fundus examination is not showing any papilledema. Whatever doll's eye movement is showing a normal eye movements. There doesn't seem to be any facial asymmetry. So more or less there doesn't seem to be any focal neurological deficit, but the patient is in persistent altered sensorium. So this may be a severe degree of eclampsia where patient might have a severe degree of encephalopathy, what we call a posterior reversible encephalopathy, which might be the diagnosis in this case. And of course, we will need imaging to look for any evidence of any bleed or any infarct or anything like that, which can explain her persistent altered sensorium. But I am not able to get any localizing signs in the brainstem, cerebellum, or any hemispheres. So that is my analysis. Her seizures are well controlled as of now.
Okay.
So maybe because CT is the immediate investigation which is available and can rule out many important differential diagnoses, we'll go for a CT scan first, and then if needed, we'll go for an MRI.
Okay, so we'll get an NCCT head done for this patient and we'll look forward for your consultation further.
As regards management is concerned, I think we'll continue with our conservative management of taking care of her BP and circulation, and if in case there is a seizure, then maybe lorazepam may be added to your Maxelf regime. I'm sure you stop Maxelf after 24 hours. So
Yes.
if there is a recurrence of seizure, probably we'll need our medications, which the first line will be some benzodiazepine, but if they are persistent, then we may go for phenytoin loading dosages, right?
Okay. Thank you, sir.
Okay. Now, if I've received the CT, that probably shows that there are some hypodense lesions in bilateral occipital lobes, which suggest the diagnosis of, there is no bleed, so which suggests the diagnosis of PRES. So to confirm the diagnosis, definitely we need MR complete examination. But on the face value, the sinuses doesn't seem to be hyperintense, so there doesn't seem to be a alternative diagnosis of a stroke or cerebral venous sinus thrombosis or subarachnoid hemorrhage, or there is no hydrocephalus. There is just edema and occipital lobe hyperintensities, which most likely suggests the diagnosis of PRES. And the management probably remains conservative with the medications which we have already enumerated, with good care of BP. It should not go out of control. The target remains 140 to 150 systolic, with 95 or 100 of diastolic will be our ideal target in this patient. Anything else the treating team wants to ask? Usually these patients take time, maybe 48 to 72 hours, maybe up to a week to get fully conscious.
Okay. Thank you, sir.